Hey everybody, it's Dr. Sarah Becker. I am not going to reinvent the wheel, so I'm using the PowerPoints that accompany your evidence-based practice book, Protocols for Best Practice. And today we're going to talk about healthcare decision making. And they do a pretty good job on these slides, so we'll just kind of roll with this. Healthcare decision making is something that you are going to be impacted by every day of your work, especially as acute care NPs. We tend to work more with the older adult, and capacity and decision making, and those things can come into question. So again, we've spoken of this before, I know in some of my lectures, that the trend now over the last decades of medicine has been that we're really getting into a patient-centered focus of care. And that means that we really are recognizing and affirming and supporting the patient's right to make healthcare decisions. So in the United States, the doctrine of informed consent and our laws require that patients be informed and involved in their own care. So because the treatments or interventions require specific informed consent by or on behalf of the patient, the determination of your patient's decision-making capacity is a critical issue that arises daily in your clinical setting. So we're going to review these again. I know you've heard of them before, but we need to be able to remember and understand what these concepts and definitions are. So autonomy is supporting and facilitating the capable patient's exercise of self-determination regarding healthcare. Again, the key word is capable. Beneficence is promoting the patient's best interest and well-being and protecting the patient from harm. Non-maleficence is avoiding actions likely to cause the patient harm. And justice, fairly allocating the benefits and burdens related to healthcare delivery and ensuring that decisions are based on the clinical need rather than ethically irrelevant characteristics such as race, religion, or socioeconomic status. The legal and ethical principles in healthcare decision-making. Okay, so we have tension between and among ethical principles and conflicting obligations, and this can create dilemmas for you as a healthcare professional. This happens frequently, to sometimes very small degrees to larger degrees. So an example they give here is a care provider has a duty to respect patients' autonomy by honoring their decisions and a duty to protect them from the harm of risky choices. So again, how do those two come together? Well, I have to respect their right to make a bad decision, but part of my duty is to protect them from harm. So those are conflicting things. Our duty becomes informed consent. So if patients' autonomy, they're making a bad decision, it's our job then to inform them of the harm and the risk that they have associated with their choice. But then at the end of the day, their autonomy overrules. So clinically, legally, and ethically valid decisions by or for patients involve a careful balancing of information, principles, rights, and responsibilities in light of medical realities, cultural factors, and concerns about resource allocation and access to care. For those of us in practice, this became a lot more to the forefront for us during COVID. Part of what I did in the facility I was at in Wyoming, excuse me, is sat on our ethics board, and we were asked to be part of the decision-making regarding allocation of resources and to come up with policies about that. So really, it was lifeboat ethics, which is the idea that if we have 6 ventilators that we have access to in our hospital and we're having a pandemic where people are having respiratory failure, what do we do if we have 12 people show up in need of a ventilator, right? So we had to make sure that allocation and access to care, but allocation was something that could have been potentially quite risky, or not risky, but relevant to us at the time. And thank God that did not happen. But it really got down to ethics. And that's a whole nother topic of conversation, lifeboat ethics, but it is fascinating. So autonomy is something that we feel the patient has a right to so long as they have capacity. So your autonomy is the right to determine what happens to your own body. So that includes both the right to agree and the right to refuse any treatments. The right to bodily integrity is considered so fundamental that it is protected by the Constitution and the Supreme Court. All persons are considered to have the potential for autonomy, which is expressed in the clinical setting through informed decision-making. A critical question is whether a patient then has the capacity to exercise autonomy. And respect for autonomy emphasizes self-governance and choices that reflect personal values. However, a focus on self-determination is largely a Western phenomena, and this is not universally shared. If you go to the literature across the world, this is somewhat of a very American thing, and a lot of other countries have different cultural and other beliefs that they don't function the same way we do. Patients from cultures that value collective rather than individual decision-making may not be comfortable with pure autonomy when it comes to decision-making. So instead, they may involve trusted others in planning their care, demonstrating assisted or supported or delegated autonomy as their preferred method of decision-making. So for some patients, autonomy may not be reflected in self-determined decision-making about treatment, but in expressions of values and goals of care. They may draw on the assistance or support of trusted others, and that does not diminish the integrity of the decision-making process, and we have to respect their choice of how they choose to delegate their autonomy. Voluntarily delegating decision-making authority to others is still considered an autonomous choice, but we cannot infer it, and it has to be something that is clearly said and stated from the patient. So if you had a situation where a husband and a wife came in, and the husband speaks solely and he says, she lets me make all the decisions, we would say, I need to hear her say that is what she feels is appropriate. I cannot infer that or assume his words to be true. I need her to validate that and let me know that that is her decision. Capacity versus competency. Okay. The biggest difference here is that capacity is a medical determination and competence is a legal concept. So competence is a legal concept in which an adult is presumed to have the ability to make decisions or complete certain tasks. So we say the age of competency in the United States is typically 18. So at 18, we can enter into a contract, make a will, etc. So if someone is declared incompetent, it is a judicial determination that because a person lacks this ability, he or she should be prevented from doing certain things. Capacity is a clinical determination that a person has the ability to understand, make, and take responsibility for the consequences of their decisions. So because the legal system should rarely be involved in medical decisions, patients' capacity for decision-making is assessed by clinicians. You will be determining capacity in your daily practice. We do this all the time, just without realizing what we're calling it. When you are doing a neuro assessment or your assessment and you're saying the patient's alert and oriented and is understanding the world around them, you have determined they have capacity. We just don't say it. It is always presumed that everybody has capacity. We document it more when it's a question of whether or not they do or if we've determined they do not. So decisional capacity in this blue box here is very important. So when I talk about capacity with my patients or their families, it is important to understand what it is we're talking about. So understand and process information about diagnosis, prognosis, and treatment options. So they have to be able to make it clear to us as a clinician that they understand this whole process. We have to feel that they can weigh the benefits, the burdens, and the risks of the proposed options. Apply a set of personal values to the analysis, arrive at a decision that is consistent over time, and then they have to be able to communicate that decision. These may sound very similar, like they're the same things over and over again, but they're not. To an article that was from the AAFP, the American Association of Family Practice. And this is a great article that talks about the ACE, which is a tool on how to assess capacity evaluation. So as we go into this, it does a really nice job of walking us through some things. Okay, so medical decision-making is the ability of the patient to understand the benefits and the risks, etc., which also includes understanding if they elect no treatment. Patients have medical decision capacity if they can demonstrate the understanding of the situation, okay? So I like this here is how they say this here. Capacity is assessed intuitively at every medical encounter and is usually readily apparent, okay? So again, you're doing this intuitively is what I was trying to say. However, a more formal capacity evaluation should be considered if there's reasons to question the patient's decision-making, okay? So we look at acute change in mental status, refusal of clearly beneficial treatment, risk factors for impaired decision-making, or readily agreeing to an invasive or risky procedure without adequately considering the benefits and risks. So any physician or provider can evaluate capacity, and a structured approach is best. And the structured approach is critical because it's going to help you guys figure out a way to document this the best way. Several formal assessment tools are available. Consultation with a neuropsychiatry or neuropsychology team could be helpful in some cases, but the final determination on capacity is made by you as the treating provider. If a patient is found not to have capacity, a surrogate decision maker should be identified and consulted. And if they're unable to give consent, the surrogate decision maker would. Okay. So it goes on further to talk about here that informed consent involves providing patients with accurate and adequate information. Patients must be able to demonstrate the understanding of the benefits and risks and alternatives, demonstrate appreciation of those benefit, risks, and alternatives, show their reason in making a decision, and communicate their choices. And it goes through here and gives the level of evidence. We'll skip kind of through that. Okay. Again, capacity differs from competence. So although the terms are often used interchangeably, again, competence is a legal term, capacity is a medical term. The lack of competence refers to global decision-making impairment. Okay, so if someone's deemed incompetent, they can't enter into a contract, they're not expected to be able to manage their own finances, etc. But capacity is something that's a lot more fluid and can be changing. So capacity refers to the inability to make decisions about a proposed medical treatment and other specific aspects of care. And so capacity can vary with circumstance. This is their example. A patient can have the capacity to make small, straightforward decisions about consenting to take a new medication, but they could lack the capacity to consent to a high-risk abdominal surgery. Generally, a patient's capacity is readily apparent. Again, we intuitively know that they're with us, they know what they're doing, they know what they're talking about, we feel very comfortable with the conversation and their decision. But you as a provider intuitively assess that at every visit. So because there's these 4 understandings, they're built into everyday dialogue and interactions, it can be assumed that patients have the capacity to make the medical decisions if their conversation demonstrates basic logic. So what does that mean? What we're saying is that as you're talking and you're like, oh yeah, we're making small talk and they're with it and they're able to participate in this basic dialogue, we start to assume that capacity is there. However, capacity may come into question if the dialogue does not proceed in a logical fashion, if there's abrupt changes in their mental status, or if they readily obviously refuse a beneficial treatment, or they have some of these risk factors. If you as the provider have doubts about a patient's ability to make a decision, then you need to do a more formal evaluation. It is your job to make sure and document and feel comfortable that you've assessed their capacity. If you as a provider have doubts, you need to do that and have it looked into. Because after you determine that, you're either going to feel more confident that you can keep going with the plan, or you can take steps to restrict their autonomy and go to their surrogate decision maker. Okay. So table 1 is risk factors for impaired medical decision-making capacity. Again, we're not talking about incompetency, but medical decision-making capacity. If they acknowledge fear or discomfort of the healthcare setting, if they're under 18 or over 85. Now I would love to know where they get this, but to me, this means pretty elderly. If they have a chronic neurologic condition, chronic psychiatric condition, what's their level of education, or do they have a significant cultural or language barrier? So those are some risk factors. If you're saying they're 93 years old, they have pretty profound Parkinson's disease, and they're bipolar and whatever, right? Those kind of things. We as providers tend to underdiagnose lack of capacity in our patients. So when they went and they studied this, they said, how often are we doing well at this? And only 42% of patients with incapacity as determined by a formal evaluation. That we as providers could only identify incapacity 42% of the time. So it's not clear whether and why and how this happens, but it is a good point to us to say we don't always do a great job at this. So we need to be alert and aware, and the onus of responsibility does fall on you as the provider. The prevalence of incapacity in healthy older adults is estimated at 2.8%. but it could likely and is higher on people with Alzheimer's disease or other comorbid states. The highest rate is among persons with learning disabilities. All right, evaluation. The first step is to ensure that there's no communication barriers between the patient's ability to understand the information and communicate with the physician. Sometimes this is as simple as, hey, do you wear hearing aids? Oh, he does? Grandpa does? Okay, well, where are they? Oh, they're at home charging? Okay, so maybe he's not as demented as we thought. Let's go get his charged hearing aids. I cannot even begin to tell you how many times I have stopped conversations and said, let's go ahead and get our hearing aid or our hearing issues lined out. And then all of a sudden we have a much more willing and able participant of the patient in our conversation. But also we have to think of things of dysarthria or dysphagia. You know, maybe they have had a massive stroke and they're really struggling to get their speech out. Those are things that then question, is it because they can't understand the situation that's happening, or is they do understand, they just have the physical impairment? And then any conversations regarding consent and big decision making, and you have any kind of language barriers, they need to be done with an interpreter, not a family member, not anything like that. You need to pause, be patient, go find your machine, go log into your account or whatever the situation is and get your interpreter. Then if we can feel comfortable that we've hit all the communication things, we can next evaluate for incapacity from medical things like medication. They've received antipsychotics or benzos or opioids. Maybe they came in altered from drug use. Maybe they're hypoxic. They're sick from something that's altering their neurologic state. Okay. And then the third step is we have to consider their values and culture. And the very common one we talk about all the time in healthcare when it comes to culture that we think of is a Jehovah's Witness that has refused blood. That may seem like they're refusing an obvious answer of if you got blood, you could live, but we have to respect that that is a cultural decision that they're going to stick by. If no communication barriers exist, the next step in your capacity assessment is a quick and informal directed clinical interview. Okay. So it goes down here and tells us kind of how we can do this. Remember, and I've said this before, I know you guys heard me say this in immersion, the patients have the right to make their right choice. They only need to demonstrate a rational examination of how they arrived at their decision. A high burden of proof is needed to restrict autonomy. Please take that to note, okay? This is not something you do lightly. You never take away a person's decision-making capacity lightly. It needs to be exhaustively and extensively evaluated, and it's like you should try to find every reason not to do that is one way to think of it. This is a huge, huge deal. All right, so some of the questions that you can ask to help determine capacity. What is your understanding of your condition? I do that a lot. What options, can you tell me again in your own words what your options are at this point? What is your understanding of the benefits? What is your understanding of what will happen if nothing is done? Okay, these are all here, and I'll link this article on your guys' Canvas. Why do you think or don't think that this treatment's going to be good for you? How are you balancing pluses and minuses of these treatments? You've been given a lot of information. Have you decided what is best? Do you need more time to think about it? Those kind of things. Okay. There are tools out there that are very helpful, and one of the common ones is the ACE, so Aid to Capacity Evaluation. That's the one that a lot of people that I know use. There's the Hopkins Competency Assessment Test, the HCAT. So let's talk about these here. This one is the ACE, this one here on the screen. So it starts off by able to understand medical questions. This is you to be able to say, so I would document at the end of this, if I use this for my visit, I would say they were able to understand medical problems. When I asked why they're in the hospital or what is bothering them the most, they were able to do this well. Able to understand the proposed treatment, yes, no, or unsure. Are they able to understand the alternative? Able to understand what it would mean to refuse? And I'll say they have refused to proceed with blood transfusion at this point and I feel that they were able to understand the option. I believe they're able to understand the options and and were able to outline and articulate their choice and why. Able to appreciate reasonably foreseeable consequences of this treatment. Able to appreciate reasonably foreseeable consequences of refusing the treatment. Is the person's decision affected by depression? And this is a really tricky and tough one. And I have run into a few situations in palliative and hospice care that come immediately to mind where this was at play. Especially, obviously, for me when I'm talking about hospice care and we are deciding about stopping treatments and moving into comfort, I absolutely need to understand the why they're making this decision. And I have the onus of responsibility to make sure that there's not a psychiatric condition driving this and that this is what they truly want and that they understand. And it is hard because if you think about it, if you're dealing with chronic, complex conditions that make you feel horribly, a comorbid anxiety and depression is not unrealistic. Or if you have an acute life-threatening situation, if you already struggle with anxiety or depression, it's not unrealistic that could be affecting their decision. And so this is when I say, do you feel you're being punished? Do you feel that you're a bad person and you deserve this? Do you feel that you don't have any hope for the future? And if there's anything in these questions that even tinkle at the back of my mind that this might not be well, I default to psychiatry evaluation. And I did have this, younger person in their 50s who had wanted to proceed with deferring life sustaining treatment interventions that were likely to help. And this person had been dealing with a chronic health problem their entire life, and they had suffered, and it was painful, and it was one of those things, but it was also stable, if that makes sense, and something they'd been dealing with for a long time. And when they just immediately were like, no, I'm not doing any of that, I want hospice, the family was shocked, people were shocked. And then as I got into the records and started seeing these things, it became apparent to me that they had been treated for depression, and actually about 6 months before then, they had been hospitalized for suicidal ideation. And once I dug down into that and asked some of these questions, and they were pretty vague about it, I said, I'm not putting you on hospice until you have a psychiatric evaluation. And the person was very upset with me, and it did not sit well with them that I was denying them from enrolling them in that. But we did work together with psychiatry, and they were diagnosed with depression. And the psychiatrist actually said that the person had capacity. They totally understood, but that they also had severe depression. It was a very kind of weird thing, and I stuck to it. And I said, I'm not putting them on hospice until we can feel confident that their decisions aren't being impacted. That's something that they could regret later. And I got pushback from that. People were not happy with that. It delayed all sorts of stuff. But I would do it again the same way tomorrow because, again, I have a duty and an obligation to my patient. So I say that here. I've seen examples. I could probably give you 5 more off the top of my head that I won't do. But again, psychiatric conditions and those things are very true that could be at play for their decision-making capacity. And then at the end of this, you can say there's scoring, and that helps you also have an objective finding. And so you can literally say, I used the aid to capacity evaluation form, and my form said, for domains 1 through 4, this, domains whatever. You can simply report what you found on your screening tool if you would like, and that gives you something to stand back on and feel objectively that you've done the right thing and that you have something to document it by. So again, there's the ACE, there's the HCAT, whatever. If you're still uncertain, if it's still gray after you've used those, then that's when you should consult others, such as psychiatry, etc. The other thing about it is that cognitive testing is something that is different for like your SLUMS score or your MOCA score or the MME scoring. They're very helpful to do cognitive evaluation, and they can be helpful when you're evaluating capacity if their scores are at the extremes of the scoring scale. So for example, if you're doing your MME and you have a patient who scores less than 20 on the 30-point MME, they are 6.3 times more likely to have incapacity, whereas patients who score 25 or higher are unlikely right? So if you do those on, maybe it's already been done in their chart a few days before, and that was, they scored 28 out of 30 on their MME, then you got to be like, oh, okay, Whereas if you pick up the chart and you're like, they scored 18 on their MME, you almost have to start making sure that you prove capacity or not. So same thing with a MoCA. A MoCA is a 30-point score, and it has been shown to predict incapacity. So in a study of 90 patients with Parkinson's, a score of less than 22 had a 94% sensitivity and 90% specificity for identifying capacity. And if we go back to what we learned in immersion and we look at sensitivity and specificity, is MoCA a good test? So if our question is capacity for sensitivity, which is snout, and specificity is spin. So sensitivity at 94%. So it's really good at ruling it out. So if you have a negative MoCA, meaning they score 30 out of 30, you can positively at 94% of the time you have ruled out lack of capacity. If you use the MoCA and it has a 90% specificity, if they score like 15 out of 30 and its specificity is spin, so now you have a 90% chance of correctly ruling in incapacity. So yes, MoCA is a great test, but it's not enough. So you would have to say that if like occupational therapy performed the MoCA and they documented your patient had a 20 out of 30 on the MoCA, you would then have to say cognition testing, the MoCA scored this. Therefore, I did proceed with my ACE and did confirm they have they don't have the capacity to make this decision. Okay. Final decision that the patient lacks capacity and therefore restricting their autonomy requires clear and convincing evidence that it could cause harm. If there's uncertainty, you err on the side of the patient. You know, like tie goes to the runner, tie goes to the patient in capacity evaluations. Surrogate decision makers. If a physician determines that a patient does not have the capacity, then you have to move to their next decision maker. Again, each state has automatic next of kin laws that you can rely on for your medical decision maker if the patient has not assigned a medical power of attorney. Up to 16% of patients in an ICU do not have a known relative or medical power of attorney, so a court-appointed health fiduciary is an option. That is messy and time-consuming. So it is much, much simpler if anybody has family or a designated next of kin or power of attorney. Then documentation, again, document a lot. We just need to. That's the best situation, is you need to be thorough and complete. Okay, so they provide a couple of cases here. An 88-year-old woman who lives alone presents to the ER after a fall. So her sodium's 120. She's admitted. Her patient records show that she has not refilled her heart failure medications in more than 6 months. On day 3 of hospitalization, she states that she's feeling better and wants to go home. Physical exam reveals she's globally weak. She can't get out of bed without assistance, and the inpatient team recommends transfer to a rehab, but she's adamantly refusing. So again, first we need to make sure that we've met communication needs. So does she have her glasses? Does she have her hearing aids? Where are we at in her ability to communicate? Is her English her primary language? Are we making sure she's able to understand what we're saying in terms of no language barriers there? Okay. But then if we go into medical barriers, we have a lot of things here that are going to contribute to confusion in somebody who is 88. Remember, if we look at risk factors, the fact that she's over 85 is a risk factor for being incapable of making some decisions. And then she's got these chronic comorbid conditions. But a sodium level of 120 can definitely cause neurologic changes, okay? And then we know she's not been adherent to her regimen for her heart failure, et cetera. So we've got lots of risk factors and reasons. And if we go through now and we perform the ACE, and we say, you cannot get up from a bed. How are you going to go home? What is your plan to go home? And if they just, I've had patients before that are elderly say, I don't know, I'm just going to do it. I don't know, I'm just going to do it. I'm just going to do it. I'm just going to do it. And they won't walk through the conversation with you and we perform the ACE. You're likely going to find that you can easily document she's not considering or able to tell us what her plan is and that there's risk for her making that decision. So if she's deemed incapable of making the decision about her discharge planning, we can defer then to the next of kin. And I'll go through this a little bit more about some of those decisions. So you have a 56-year-old man with schizophrenia is brought to the ER by his brother. He's got a large non-healing ulcer that's obviously infected. He has diabetes and he stopped taking all his medication 6 months ago. He's got disorganized thinking and describes hallucination. He refuses treatment and says the government's trying to kill him. I hate to be crude with the saying of this, but this is a slam dunk. The man has a psychiatric condition. He's not oriented and aware with all of these things. We would very quickly demonstrate lack of capacity and impaired cognition, and he would be likely detained is the word I want to use, but that's not the word I want to say. We would put him on a hold and he would go into inpatient psych against his wishes. He wouldn't have to consent. Case 1 is an example of a patient who may understand her situation and treatment options, but may not appreciate the consequences of her decision. So if she was discharged home, she lives by herself, she wouldn't be able to keep herself safe, and that would lead to harm. So again, like what they said, we would probably say that we can now take steps at discharge to take away her decision to make sure she discharges to safety. And then number 2, we talked about, that's pretty straightforward. I do think that it's really important to make sure we understand that when we are asking for certain decisions to be looked at for capacity, each decision has to be separate and a separate discussion. What do I mean by that? So for example, this woman in case number 1, she may lack the capacity to make a complex decision about medical discharge, but that doesn't mean she can't make a decision about whether or not she is in pain, or whether or not she wants to get on the bike and practice that exercise. So just because we take capacity away for a certain decision doesn't mean that she can't have choices in her life. It doesn't mean that we've taken away any of her ability. And I think that this is something that gets confused for people and is difficult for people to understand. The other thing about medical decision capacity is it's a medical thing, and we just identified for case number 1 that this woman has a lot of medical things that are wrong. So in 3 weeks, we could possibly reassess things and she could be back to her baseline. She could have her sodiums corrected, she's back on all of her regimen, she's feeling better, she's sleeping better, her cognition improved, and she may be able to do that. So just because at that date, at that time, we said she didn't have the capacity to make discharge decisions doesn't mean that's going to stick with her for the rest of her life. Back over to the PowerPoint slide, when we talk about consent and refusal, we have to be cognizant and aware that sometimes our interventions can involve a wide range of benefits, burdens, and risks. And sometimes it can be a lot of information and be a bit overwhelming, so that we have to understand that the informed consent process can be done over time rather than in a single one discussion. And education about an intervention can improve decision-making capacity to give safe, informed consent. So when you document informed consent, we do this all the time as nurses. You're going to do this a lot in your practice, but I want to really step back a second and make sure we are understanding what the informed consent means. So if someone signs it and this is their consent and we're calling it informed consent, we are saying that they had decisional capacity. We disclosed all the information needed to make that healthcare decision. Understanding of the information was provided and they have a voluntary choice, and that consent or refusal has been documented. Decision-making authority should be made by capable patients in response to the information they receive. Again, healthcare is a collaborative endeavor. The determination of decision-making is among the most critical tasks in your setting. Surrogate decision makers should base their decisions as much as possible on what is known of the patient's preferences or what is considered to be in the person's best interest. This is a really hard spot for us to be in healthcare, when maybe you have cared for the patient off and on for a year now in your heart failure clinic, and they get acutely ill, they come in the hospital, now they can't make their decision. And so we get a hold of a son whom they haven't seen in 2 years and they don't get along well and whatever. And the son walks in and maybe starts making decisions that in the back of your mind, you're like, Mr. Smith would never have wanted this. Then it's, our prerogative then as the healthcare team to be able to say, look, I spent a lot of time with your dad, and help guide that process to really encourage them to make decisions that are in the patient's best interest. But at the end of the day, the decision maker still is the surrogate, and we have to respect their autonomy to make the decisions as the surrogate maker. The goal, again, of using any of these tools and even doing capacity in the first place is we want to optimize safety, and we want to protect autonomy. We don't just want, on day one, when they came into the ER, they were confused and say, well, he obviously can't make his decisions 3 days later. That's not what we're trying to do. We have to be very careful and thorough and diligent as we use these. I would say that a gold standard of care would be that you don't say, it is obvious to me the patient lacks capacity. No, you should say, I have concerns about their capacity because of this conversation, these risk factors, etc. I used a tool, etc. And you need to make sure you were thorough and complete and very clear on how you came to the determination of the lack of capacity. Some of the things to remember, we always should give them the benefit of the doubt. We assume that they have capacity until we have evidence contrary to that. So I like that this statement is in here. Capacity assessment is important because some patients lack the ability to appreciate the consequences of their decision. So honoring the decisions of a capable patient, we define as an act of respect. But deferring decisions of a patient who lacks capacity can be an act of abandonment. So clinicians agree that the ability to understand the consequences of the decision is an important indicator of capacity. The presence of cognitive impairment does not automatically mean that the person lacks capacity. Okay, so evidence shows that safe and sufficient decision-making is retained in early stage dementia. Persons with mild to moderate dementia can make or at least participate in making their treatment decisions. But impaired memory recall then might be a barrier to demonstrating understanding of the treatment options. So earlier when we said they have to stay consistent, I have seen it in dementia patients that at the moment, in the moment, when they're in the morning, they're having a good day, they know their family, they're very capable in that moment to make decisions. And then by maybe 7 o'clock at night, 1 in the morning, they start saying other things. No, I would never want surgery. No, 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 no. And capacity can be fluid. They can have capacity at 7 in the morning and they could lack capacity at 7 at night. It gets very hairy and gray, and that's why these are not one and done kind of conversations. Again, we went through that on the other thing of some of these tests and tools. So again, decisional capacity should be decision specific. And that's what we're talking about. Capacity is fluid. For patients with mild or moderate dementia, periodically assess their understanding about treatments and interventions. Approach the patients for discussions when they have their lucid windows. If you know that they sundown and by 6 o'clock at night, they're not always with it, we don't make decisions at 6 o'clock at night. Okay, so we've given and created 2 ways for patients who lack decisional capacity to identify their surrogate. They can have an advanced directive or a POA. Advanced directives will include instruction directive, I cannot speak, which is the living will. That's a list of interventions the patient does or does not want. Again, I spoke about this in the last lecture. They're often kind of vague and nonspecific. The appointment directive is the durable power of attorney for healthcare, medical power of attorney. A healthcare surrogate may be any capable person 18 years or older who can also show that they have capacity to make decisions. I will say this, remember that we do not invoke surrogacy for decisions until the patient cannot do it. So you will have patients that are completely with it, they still have their cognition, they still have all of their capacity, and they're making choices that maybe the family doesn't like. And you will have a daughter or an uncle or a brother show up and say, well, I have power of attorney, can't I just make that decision for them? Again, no, that is only enacted when they lack their decision. So a healthcare surrogate, absent explicit instructions from the patient, verbally or in the advance directive, decisions by others are based on either substituted judgment or the best interest standard. Family consent laws, again, are state by state. Healthcare goals and treatment preferences typically change as they have changes in their health. So typically people are a lot more aggressive when they're healthy, and then they start to restrict things as they're failing in their health. I know you guys read hopefully all of this stuff too, so I don't want to get this to be too long. Again, just as patients have the right to make medical decisions and to receive their medical information, they also have the right to not be burdened with unwanted information. So older adults or those from other cultures sometimes want to shield patients from knowledge. However, providers should ask patients about what information they want to receive, who they want to be involved in their care, and their desired participation in healthcare outcomes. I just had this not that long ago where an elderly man said, I actually don't want to know all these things. I trust my daughter and my son. Whatever they want is whatever I want. And he totally had all of his marbles, and he clearly had capacity. And he did. He said, this just upsets me. I know I have a cancer. They know what I want. I don't want to talk about it anymore. Let's go down one more here. All right. So these are some of your strategies you can use. I would actually really read these, you guys, and keep them in your pocket, even for when you're out and you're in practice, because they are ones that I think are pretty darn helpful as a practical way to document, okay? So a good documentation would be patient lacks the capacity to make the decisions about participation in this drug study. Patient lacks capacity about what surgery, XYZ, and this is why. Patient lacks capacity to make medical discharge decision making because of this, okay? Do not ever say, patient lacks decision making capacity, period. Again, because you would be implying that they can't make a decision about anything at all. Or patient's disoriented, thus they cannot make decisions. Not helpful, not a good practice. Don't do that. Engage patients in discussion about their healthcare goals, values, and preferences. Again, we always encourage patients to have goals of care conversations well before they're in crisis or not able to participate in conversation. Be sensitive to all the factors that could play in, such as race, ethnicity, religious decisions, culturals, etc. And again, go through and make sure we don't have any barriers, etc. So again, it's kind of different to have, I keep saying again, and I don't know why. It's a little different to have kind of that article thrown in there in the middle of it, but I will add that article as well. So take home of this, I would say, again, for clinical practices, remember you are intuitively assessing capacity every interaction you have with the patient. Patients get the benefit of the doubt. Mini mental or cognitive testing does not also definitely define capacity, although you can use them as justification of why you were questioning capacity or as building your case for lack of capacity. Your capacity evaluation needs to be very clearly documented and documented well. Remember that capacity is fluid and this can change over time. You as your patient advocate should always be giving them the benefit of the doubt and making sure it is reassessed. Follow your state laws regarding next of kin and surrogacy if they don't have a POA. And just remember that this is the burden of determining capacity does fall on you as a provider, and it's a very, very serious decision that we should take very seriously and do cautiously and wisely, and use your tools and ask for help if you need it from your colleagues. All right, as always, please reach out if you have any questions or concerns.